next speaker is Dr. Santosh Honavar sir, who is going to give us the tips about the innovative teaching tools.
And also try to better himself than Himanshu's presentation.
Maybe my next presentation will be better after having speak about innovating teaching tools. I didn't know exactly what he meant, but this is what I have prepared and I hope he likes it. Yeah. This is traditional face-to-face classroom teaching. Well, when you have residents, the class may not be as big as this unless you are in RP Center or regional eye institute. But we do have postgraduates sitting across and you are standing here and they're sitting there and you face them and teach. This is absolutely traditional way of teaching. There's nothing bad about it. This is all we have all learned right from our kindergarten to now. And in addition, in our medical profession, this is what happens. When you have residents or fellows around you, when you're seeing a patient, they're flocking around you and you tend to explain to them. Patients often don't mind this. This is part of medical training. You're showing them and teaching them. You're showing the science, you're asking them questions, and if somebody doesn't know, probably for the next case they read up. Similarly, when you are in the OT, they're watching through the side tube or on the video monitor and you're teaching. This is teaching in the OR. So for residency and fellowship purposes, didactic, clinical teaching in the clinic and teaching in the OR all matter a lot. When this is all put together, final training happens. But when people looked at it, there are a lot of research that has been done on traditional teaching, clinic-based teaching and OR-based teaching. And when it was scientifically looked at, what percentage of trainees actually retain what percentage of knowledge that was conveyed to them very clearly. Not that it was conveyed in a casual manner. It was intended to be conveyed and it was conveyed in a very clear way by a trained mentor, like somebody like Himanshu. What percentage of trainees actually got that information, it penetrated into their brain, and how many actually retained after a week? That was the time that was taken to evaluate. Only 50% had penetrance and 25% had retention. So it is not really good. What we are doing is good. But when, from the trainee's perspective, probably they'll have to listen to it 4 times or 10 times for them to even get to the level of 75%, 50%. Which is still not good because you want to convey 100%. Whatever knowledge I have as a trainer, I want to give it to my trainee to 99% or 100%. So that he is equal, at least at the time of completion of his residency or fellowship, and maybe even better once he finishes. So what are the innovative training tools or teaching tools all about? They mirror the trending technology because, well, we have this classroom and I'm teaching, but we are using slides. That's fine. But what if you had when the previous speakers were giving a talk, what if you had a VR headset in front of your eyes, which was absolutely immersive, and you were able to hear to my voice in a very stereophonic way, not in a way, depends on where you're sitting in the room and where the speaker is. And what if you're able to see these slides in 3D coming at you? What if I use a lot of animations and showed the structures of the eye and different layers of the eyelid while I was dissecting? Don't you think that would be more rewarding as a trainer? Possibly yes. So these technologies are currently available. These are not remote. We use this to watch movies. Why can't we bring them in to teach? That is how I hit upon the idea of 3D surgery. We recorded surgeries in 3D and I show it in 3D because then you get the perception of depth. Otherwise you're just looking at a plain surface and you may or may not understand. The infusion of technologies into teaching actually helps a lot. Second is blended teaching. When you combine your classroom teaching with infusion of technology, it's called blended teaching. That really improves the penetrance and perhaps retention. And finally, the aim is to optimize learning. So these are some of the tools that are available. Technology-based teaching tools is what we have: e-learning, simulation-based learning, virtual reality, and augmented reality. E-learning started with Eklavya. Eklavya was not a traditional learner. He was somewhere there and he learned. So E for Eklavya actually is for e-learning, and he was the first documented e-learner, right? Now, how do we have e-learning? Now, your first year resident has to do retinoscopy and he can't sit in front of a patient and start imagining. So, if he has done this simulation, retinoscopy simulator, which is available on the AO website, he'll know the point of neutralization. He doesn't have to cut a sorry figure in front of the first patient that he is looking at. He already knows what is the point of neutralization. He will probably be able to identify the grades of RAPD much better. Just a simulator. So all you need to tell your first year resident before he goes to his first patient, look at the simulation 10 times, 15 times till you register what you are going to look for. And then you go to a patient and look for this. Possibly it will make a much better impact. Theoretical knowledge, of course, we have IWiki et al., Atlas of Ophthalmology, American Academy of Ophthalmology, closer home we have the entire AIOS proceedings and the webinars, everything chronicled on one AIOS. There's a single YouTube channel. We have iFocus with 400 odd lectures. We have podcasts which are available on Google. For example, look at this. On Apple, you have hundreds, thousands of podcasts. You can actually listen to them while driving. If you're bored with music, looping music, the same one, new song hasn't come into the market. Basically, you can listen to this podcast. You have this iTunes podcast. You have ophthalmology podcast. You have essence snippets. Shankaretra they have this podcast, 15-minute, 10-minute podcast. All right. This is simulation-based learning. This is currently happening at AIOS, Delhi. If you care to visit, you can actually register for this course. It's a 5-day course for phacoemulsification and ascites and complications. It is a little expensive, but it is worth the investment. Here, the kind of teaching that happens is really good. You are actually much better off when you have undergone this training and go back to your patients. Your complication rate reduces, your speed of surgery improves, and the understanding of tissue management, how to hold the tissue, where to hold the tissue trauma, everything becomes much better. And short of it, you have this internet-based simulation. You can see this Cataract Master. This is available online. This is by American Academy of Ophthalmology and Mass Eye India collaboration. Each step of cataract surgery can be simulated online on this tool, and you can click on Get Help. Suppose you don't understand a particular step, Get Help. It will explain to you theoretically and show a real video clip. What just happened if you have done a PC rupture, then you can say what just happened. It will explain to you why you had this and how you can avoid it, and further explore the topic in terms of theory. This is VR Magic, where you can have virtual reality. Virtual reality is totally immersive. That means that you are wearing a headset and everything is controlled through that. You are totally cut off from reality, rest of the world. I am wearing a headset, I am not seeing any of you, but I am seeing the surgery or whatever that is going on. Whereas augmented reality, you have the real life around you. That means that I am not totally cut off from everybody else, but I am also watching what is happening. And these modules are already available for most of the purposes, such as teaching of ocular anatomy, cataract, trabeculectomy, etc. And closer home, Ramesh from Gandhi Mahatma Eye Hospital has made this augmented reality template for teaching disc evaluation. Very beautiful one. I've used it and seen. You can actually get into the eye, get to the optic disc, look at the nerve fiber layer, look at each layer of the retina and come back. Then interactive teaching tools, we have flipped classroom, PBL as Himanshu pointed out, case-based learning and gamification. Flipped classroom is very simple concept. This is traditional lecture. I'm giving a lecture, you're listening to it, you may forget it, you may go back and read about it. In flipped classroom, I would have already submitted to you my lecture in in the form of a recording or a link on a YouTube or wherever. You would have heard it and you have to come back to discuss. Now I would not be giving a lecture standing here. I would only be taking questions, or you might be adding to what I have already taught you. So this is flipped classroom concept, where their time is not wasted in giving a lecture to you, but you are actually discussing the topic threadbare in 1 hour. Imagine if you had 1 hour to discuss a topic, then sitting and listening to a lecture, and then you go back. What do you do after traditional teaching? You might have to go back and read about it more. I might give you a homework. Well, that doesn't happen in flipped classroom. You have already heard the lecture, you come back and discuss, and you take back more knowledge. PBL and CBL are very good concepts. In traditional concept, I am telling you what to do. You memorize it, possibly for a while, and you may forget about it. In PBL, The problem is assigned. I'll give you a case of neovascular glaucoma with intraocular pressure of 42 millimeter of Hg. Now you identify what you need to do with it. How do you investigate that patient further? What medical management would you start? What kind of surgery would you do? You come back and discuss that. Case-based learning is something similar. Well, gamification, you have Kahoot. If I had Kahoot built into my presentation and all of you had keypads, or on your mobile you can download the app and you can use the game pin and use it, I could have quizzed you. How many have used, say, PVL? How many of you have used CBL? How many of you have actually done virtual reality training? I could have quizzed you and you would have given me the answer. If 50% had answered that they have done it, it would have come on the screen, and that keeps you interesting, interactive. So this is gamification. You can also award. Suppose you have a quiz built into a presentation, you can see how many of you have done it really good, and then you can give them a reward. So in conclusion, I would say that traditional teaching is time tested and is good. Newer innovations address the gap between the ear and the brain that traditional teaching conventionally comes with. It is bilateral, it is interactive. That means that now nobody has spoken so far, and maybe the chairpersons and the moderator might say a few words just after this, but none of you have spoken. In new teaching methods, you would have spoken at least 50 to 60% of the times, and I would have spoken maybe 40 to 50% of the time. So it's absolutely bilateral and nearly equal, provides divided responsibility. Learner has more responsibility than the teacher, because you want to learn, I want to teach. That's fine, I get satisfaction by teaching. But what about you? You want to learn, otherwise why have you come so far to Dehradun? Of course, there are other purposes as well, but you have come, right? So you have come and you're sitting here and you want to learn. So doesn't that give you equal responsibility to learn? And that doesn't get fulfilled in traditional teaching. Optimal interaction and depth of learning is much better, and retention and appropriate reproducibility probably is going to be much better. Thank you so much. Himanshu, how much? 1 on 10? I'm asking nervously because I'll improve next time.
Eye contact.
I know. Himanshu, you got to give us a treat. This whole class a treat.
You should have sent this lecture before. You would have seen True.
So, thanks Santosh, excellent. I think the amount of knowledge that is already there in the media is huge today, in today's world, which was not there when we were students in MBBS. So this has definitely changed the protocol of learning and teaching as well. And these innovative tools that you mentioned are very important, and that interactive innovative session, which is approximately 50% in and out, so that becomes more important. That gives the class that connect between the teacher and the students. So that is important, and that's what the virtual teaching will not provide, or partially, maybe very little to provide. I think these innovations, I'm sure senior professors like GP80 and others also do employ. It's to give the attention to what you're teaching, number one, and number two is to inspire the student to go back home and take up that chapter and read it thoroughly. Because everything you cannot teach in 45 minutes, but everything has to be learned, and that inspiration has to be taken back. Thank you.